What I've learned actually, in fact, it's the whole world is learning. Neonatology is less is more. The less you disturb the baby, less you do the intervention in the baby, less harm will be done. And now we are realizing that we don't know much about babies, really, how they are in utero, how they should be carried out in utero. Initially, हमने सोचा था when the baby is born, they don't know how to breathe, and we should intubate all the babies who are less than 1.5 kg. Now, increasing evidence have come up that intubation should be the last resort. Ventilation causes much more harm than benefits. पहले सोचते थे इनका the GIT is so weak that they will not be able to tolerate. Now evidence are enough that early you feed the child, better they are. So now I think everybody is on the same page that we should be more physiological. More babies to NICU, coming to NICU, jitna antibiotic denge, the microbiomes are not going to lose this war and they will develop resistance. Or the resistance will be much, sinister than the primary infections. So I'm just going to talk about the few, basic things that really change the outcome of the baby. And from the gynecologist perspective, the first thing should be prematurity prevention. And all of us are very scared that we should deliver now. Inside the womb, if the baby dies, it will be a lot of issues. But outside also it's going to be the same. So what I think that unless there is a threat to life of the mother, ideal delivery times should be practiced. And it is there in ACOG guidelines. The paper in 2022, they published the latest guidelines, 221 I think so. And they said that there are only a handful of indications there the baby should be delivered less than 32 week. Otherwise they should be prolonged more than 32 week. And one thing, it's very, what we think that if the baby has crossed 34 week, it's a late preterm, and late preterm are as good as term babies. No, madam, they are not. Late preterm are preterm babies, and they do have lot of problems. So late preterm should not be taken as a term babies. They are late preterms, and late preterms go to NICU and they complicate more. And the problem is something happened to a very preterm or extreme preterm, it is acceptable. But something happened to a late preterm is a problem. A single prick increased the incidence of infection by at least 10 times. And infection in community is easy to treat. Infection from NICU is a multi-drug resistant organism. So we have to be very careful. We should not give a chance to anybody to let them go to NICU unnecessarily. If they required, yes, we are there, but unnecessarily, no. Preparation, antenatal steroid, and DEXA is the only thing, madam, and her, the East Delhi group is all practicing DEXA. I've been going to a lot of, places. Most of them have been giving betamethasone. That is not the way. Betamethasone should not be given in Indian settings. The betamethasone acetate and phosphate salt is not available. MgSO4, if time permits, if the delivery is imminent within 24 hours, less than 32 week baby, like babies should antenatally receive MgSO4. And if there are PPROM, antibiotics are indicated, but not augmentin. Augmentin increase the risk of NEC. Oracle trial is there. There were two trials, Oracle 1, Oracle 2. Oracle trial 1, Oracle 1 supported antibiotics. Oracle 2 said no augmentin. One thing that we really neglect is delivery room temperature and airway management plan. Now it is the time that the gynecologist should start asking their neonatologist, what are you going to do with the boy or the baby? Because everybody gets pregnant because of the baby. And if the result is not good, I think we have not made all the efforts. And you've been seeing the mother for 9 months. And she's there, she's been taken care of, you are responsible for everything. They have a lot of trust in the gynecologist. What I have seen is, whatever the gynecologist say, they accept it. Whatever I say, that you do not accept it unless the baby stays with us for like a month or so. So the gynecologists have real right over the baby. And they should know what is going on with the child. What we can help is, if we increase our temperature in the OT from 20 to 25 degrees, we can decrease death by at least 1/4, because most of the babies who reach NICU, they are hypothermic. And initial 1 hour of hypothermia result in lot of acidosis. That acidosis is going to hurt the baby because there are lot of changes. there is cerebral vasoconstriction, cerebral vasodilatation, and this alteration of when they scold, there's a vasoconstriction. When we rewarm them, there's a vasodilatation, and this constriction, the dilatation cause IVH. If you want to prevent an IVH in a preterm child, do keep the baby in the most physiological place, physiological space. Do not have a hypothermia cycle. Do not change the temperature that much. Airway management plan is important. What if you do not prepare for disaster, you are preparing for a disaster. The truth is this. And now intubation should be the last resort. I think so. In our unit, we have lost the, art of intubating the child, because we are not intubating them. We are mostly keeping them on non-invasive ventilation, be it CPAP or be it BiPAP, but we say here is NIPPV. So if you keep the baby on NIPV, most of the babies, at least all the babies more than 700, 800 gram, do not require mechanical ventilation. Putting a tube in there is going to suppress the effort of the baby. First of all, a foreign body increase the risk of infection, and we don't know what ventilation the baby wants. The baby might require a 5 ml per kg or a 4 ml per kg or 6 ml per kg, depending on their requirement they breathe. But from outside with a ventilator, we give them fixed breath. I don't know, we check ABGs at the most 2 times a day. And that is not good enough. That's not good enough. When they are ventilating, self-ventilating, when they are NIPPV, they know what they ventilate. If the baby have high PCO2, they'll increase their rates. If the baby is calm, not in pain, they need a low PCO2, they'll decrease their rate. So it is automatic. So that's the best thing. So you ask your neonatologist or pediatrician, how are you going to manage the airways? Are you going to intubate the child prophylactically or no? Are you going to give surfactant? Surfactant also is not required left, right, center, madam. What I have realized, I train a lot of fellows, and what I see, it costs more damage than benefit. A 600, 700 gram baby is difficult to intubate. And what I have seen, most of the baby, especially the younger one, cannot intubate in a single go. You intubate in 2 or 3 goes, they increase the cerebral pressures, and that is the most common cause of IVH. And once there is IVH, there's no point keeping the baby in NICU for a month or so. The outcome are never going to be the same. If you can prevent that IVH, in Western countries, they are not even intubating for surfactant. They're giving LISAs. LISA or MIST, minimal invasive surfactant therapy. But here we are intubating prophylactically. Sir, apnea hoga to kya hoga? Apnea hoga to us time dekh lenge na. But do you need, and believe me, unless there are sepsis, there are very little apneas. And if there are apneas, you can just stimulate the child. Just for prevention of apnea, you should not be intubating. And last thing, what I'm going to tell you, everything is going to be extension of this slide only. We have to prevent hypoglycemia. At least 80% of preterm babies who enter NICU have a blood sugar of less than 50. At least one episode of documented hypoglycemia is there. And the problem is, initially we were in the delivery room, we were stabilizing the baby. When we get to the NICU, the sugar is the last thing to be checked. जब IV डलेगा जब तो sugar check देंगे उसको, जब तो sugar push करेंगे. And by the time the sugar comes down to 20, 30. I don't know what damage they have done. So we have found out that most of the babies, most of the extreme preterm, especially babies, have some neurodevelopment impairment. Why it is not related to hypoglycemia? How can it be prevented? If you check, I have made a unit protocol that one sugar should be checked within half an hour of admission to NICU. And we have found out a lot of babies have a sugar less than 50. But what we could have changed, what we did change is, we prevented those less than 50s to go into less than 30s, where the real harm occurs. So we now, for last 1 year, we don't have a single child having a reading of less than 30. But we have done it. If we find that the sugar is less than 50, we give a D25, in the buccal mucosa, and sugar get absorbed from buccal mucosa very, very fast. If possible, we put a OG tube and give D10, 1 ml or 2 ml per kg. and that's going to increase the sugars for, let's say, half an hour or 1 hour. By that time we can put our lines, we can put a cannula or whatever we want, or feed whatever we want to do. But that 1 or 2 drop or like 1 ml or 2 ml is going to make a lot of change. And this is, one intervention I'll suggest everybody will be doing. And the Western people have started accepting it. They're giving buccal dextrose. Even in for gynecology also, if you find there is a obese mother or a diabetic mother whose child is at a risk of hypoglycemia, you can just at delivery, you can just ask them, please check a sugar. If even the sugar is not possible, you give a D25 in the oral mucosa, 1 ml or 2 ml. The baby is not going to aspirate of it, and the sugar can be maintained for at least half an hour to 1 hour. One good intervention. The feeding plan. What we are scared of, बच्चा 500 ग्राम का है, वैसे NEC हो जाएगा. If you don't feed, there will be definitely an NEC and a sepsis also and a failure to thrive. If you feed, at least there is a risk of NEC, but it is not higher than not feeding. There have been ample studies now. Last was the shift trial that said even for extreme preterm, you have to increase feed fast. And initially we used to say that even extreme preterm should get a full feed by day 13, day 14. Now it is a trend that you have to get the baby to full feed by day 5 or day 6 if possible. If not possible, last should be 10-15 days, not more than that. And no babies without inotrope should be kept fasting more than 24 hours. That's a dictate. If you want to have a good outcome, you have to do that way. If you don't do, then there is a problem going on. And one thing is, with feeding, especially in the Indian scenarios, the outcome is going to be better, because here in our unit, or we do not have ideal TPN. We just make a makeshift TPN. Sometimes the proteins are not good. Sometimes we are not giving lipids. Sometimes we are not giving multinutrients. Breast milk has all those properties. It has a probiotic. It has HMOs. It has everything possible. It decreases the risk of infection also. The lesser is the cannulation, less is the foreign body, less is the risk of infection. So what the gynecologist can do, they can, ask the mother, they can, how to say that, do a prenatal counseling, that the milk is, especially for the preterm babies, the milk is going to be important. You have to get the milk early. So if you do not, get the milk early, there will be problem. There will be a lot of problem. They should express whatever comes. Even a drop of milk is going to be helpful. Even a drop of milk is going to be helpful. What we have started doing is, we are doing it colostrum oral paint. Colostrum oral paint, it has lot of immunoglobulins, and those immunoglobulins increase the immunity of the child. It's like a vaccine for the child. If feeding is not possible, okay, you just put some colostrum on the buccal mucosa. That's going to help a long way. Antibiotics sometimes are important, sometimes are unnecessary. Way too unnecessary than do. Prolonged antibiotic have increased the risk of NEC multiple folds. NEC is necrotizing enterocolitis, and increase the risk of sepsis multiple folds. Those babies who have received antibiotic more than 72 hours unnecessarily without indication have more late onset sepsis, and their late onset sepsis is more dangerous because their infection, their bacteria are more resistant. हमने तो बैक्टीरिया सारे मार दिए, रेजिस्टेंट कैसे हो गया? Because you can kill the pathological bacteria, but not the physiological bacteria. And the bacteria are friend. The pathological and physiological bacteria are friend. वो physiological bacteria, pathological bacteria से का plasmid ले लेता है, and that plasmid is transferred to the pathological bacteria again, and the pathological bacteria with high virulence have that plasmid that is resistant to that antibiotic. The same antibiotic is not going to work on the later on, or even sometimes the healthy infant keep on shedding that plasmid, and even after months they can have a resistant infection again. There are the few high risk preterm high risk babies that should be taken care of. The intrauterine growth restrictions, they have a risk of hypoglycemia, absent reverse end diastolic flow. If they are 34 week, we tend to not feed them. They're the subclass where we don't tend to not feed them for first 48 hours and then slowly increase. PPROM, there are risk of infection. Antibiotics should be given, but not high antibiotics are always. Difficult transition, resuscitation, they might be, at a higher risk, and we have to check the lactate. Sometimes pediatricians are so scared, even a lactate of 5 or 6, we won't feed the child. See, if the lactates are 8 and 9, we will not. If the baby is not encephalopathic, the baby's activity is fine, the baby do not need high respiratory support, and the lactates are just borderline high, 5, 6, there is no contraindication to feeding. Some mothers, especially who are nitrates, they might have, lot of issues. Their babies need to be taken care of. Nice. So this is the ACOG guideline 2021, which says what I was going through. I'm not going to teach you in this, but the indication of delivery for any of these things is not less than 34 weeks. Not less than 34 weeks. None of them have an indication of less than 34 weeks. If anything you go, even oligohydranose, growth restriction, abnormal, SD ratio in umbilical artery Doppler, they are all 33, 34. Only indication for less than 32 week is absent or not even absent, reverse and diastolic flow. That is also 30 to 32 week, not less than 30 week. Delivery less than 30 week is only indication is ductus venosus changes, nothing else. So if it is MCDA with the FGR, then it is 32 week. If it is absent end diastolic flow in umbilical artery, that is 32 week, and reverse end diastolic flow in a 32 week, that is the 30 week. Otherwise, ductus venous changes, not even early ductus venous changes, late ductus venous changes, they are indication to deliver less than 30 week. Otherwise, no. So sometime like leaking PV, it's not an indication for delivering at 32 week. It can be taken to 34 week. Preterm onset of labor should not be delivered early unless they deliver by themselves. Most of them, get delivered near term or term also. Just twin delivery is not an indication to deliver at 34 week. It is MA. Monochorionic monoamnionic twins should be delivered at 34 week, no less. But DCDA twin and other twins should be delivered at 34 week, 36, 38 weeks. So even maternal conditions, they are all of them need to be delivered at either late preterm or term. Only is gestational hypertension with a severe high BP should be delivered at 34 week. Mild should not be delivered at 34 week. So this is Society of Maternal Fetal Medicine. What they have recommended is this: normal Dopplers deliver at 38 week, decreased flow 37 week, absent 34, reverse and diastolic flow 30 to 32 week, not earlier. This is the crash approach we go through. That what have changed is cord management plan. We should try to give as much blood as much possible to the babies. So cord management plan has to be discussed. If the child is vigorous, the recommendation is not even 30 seconds. It is now 60 seconds of delayed cord clamping. Believe me, even the child is not that vigorous also, the umbilical cord is giving oxygenated blood to the baby. Better than I can do. Because oxygenated blood is there. And baby has been staying in hypoxic environment of saturation of 60s in utero. It is ischemia that causes damage to the baby, not hypoxia. It is hypoxic ischemic encephalopathy. Saturations of 50, 60, 70 do not cause much harm to the child. Cyanotic heart defect, they remain at a saturation of 70, 80 whole life and nothing happened to them. So hyperoxia is a problem. Even a minute of 100% oxygen can cause enough damage to cause free radical injury, cause ROP in an extreme preterm child. Aggressive feeding is important. I told you, decreases NEC. Sepsis prevention is first and foremost. In my unit, we do not do hi-fi things. We hardly put PICC lines once in a month, not more than that. We just get off the lines fast. But what we do is I make sure every nurse wash hand properly. and they do a good sanitization. Washing hand means 40 to 60 seconds. That means at least one step has to be repeated 15 to 20 times. In a hand wash and a hand rub, every step has to be repeated at least 5 to 10 times. What I say that you have to fill your palm, and the hand rub should dry when you touch the child. If you have touched the child with a wet hand, that means you're giving more infections. Sepsis prevention is the key in neonatology. Feeding, sepsis prevention, and prevention of hypothermia, hypoglycemia. If you've done all these things right, no child. IVH, so nobody can prevent it. Steroids can do prevent, but if there's no IVH in first 3 days, but I tell the parents that extreme preterm have all those complications. But if the child do not have complications in first week of life, by day 7, they will do good. But do we have time? Actually, we started late. Do we have time?
Yes, sir. Yes, sir.
I'll take 5 to 10 minutes more, ma'am.
Please, sir.
Oh, thank you, ma'am. Thank you. So the cord clamping plan has to be discussed. There are a lot of advantages of delayed cord clamping. The death decreased by at least 25%. The inotrope decreased at least by one third. Inotrope, the blood volume is there, and it's the best volume expander. It's the isotonic, most isotonic with lot of RBCs. Then decrease the risk of blood transfusion by almost more than half. The jaundice is similar even in RH also. In RH isoimmunization also, the risk of jaundice is similar because maternal blood hardly get transferred. And long-term stem cells are there. They prevent BPD. Even now, those chronic lung disease we were saying, the treatment is stem cell transfers. They're autologous stem cell transfer. They're going to help the baby big way. The different type of cord care plan, what is early cord clamping, that is not recommended nowadays. Intact cord milking, that is for more than 34 weeks. Delayed cord clamping more than 60 seconds is the ideal way, or cut cord milking. If the baby is asphyxiated, we have to cut the cord immediately. Okay. But whatever length is there, they can just do a cord milking in that. That's going to be beneficial. At least more than 34 week. Can be seen 32, 34 week is plus minus, but less than 28 week, no. Less than 28 week, cord milking cause IVH. So extreme preterm children should not be given, babies should not be done, cord milking, but delayed cord clamping is possible. And even if they do not receive respiratory support for first 30 to 60 seconds, doesn't make a difference, because for 30 seconds, so we have to do dry and stimulation that you can do at the mother's abdomen also. So at least 30 seconds won't make a harm. So what is recommended? More than 34 week, you can just give cord milking, cut cord milking, and 28 to 32 we don't know. If possible, yes, we should do. Less than 28 week, no cord milking, but delayed cord clamping for 60 seconds, if possible, definitely should be done. Definitely. Respiratory care, we told, this is the best invention for neonatology. It is a T-piece. It gives a PEEP, that is CPAP, and a PIP, that's a ventilatory breath. Nowadays, we say intubation is not an emergency. Intubation should be an elective procedure always. This machine, the cost varies from 30,000 to maximum of 1 lakh. And if it is there in the labor room, in Amrita, we have seen only one asphyxia in last 1 year. It's not that the baby do not come crashing, they do come, but this machine gives you a PEEP and a PIP, and most of the babies comes good with it. At least those babies who have stage 1 HI do not enter into stage 2 and stage 3. So this machine, every neonatologist, every pediatrician should be, should get used to it. And the training is just 5 to 10 minutes, not more than that. Easiest thing to use. Just you have to buy it once, 1 lakh rupees or 50,000. There are a lot of machines. You just invest in this. This is called T-piece. If you take it from Fish and Peckle, this is called Neopuff. And one thing is, it can be used for transport. Very easy machine. Transport also you can use, improve the FRC, better lung compliance. One thing, oxygen by nasal prongs or hood should not be given. Never be given. So for on the left hand side of my screen is the purple one. They are the TPs. How see how rhythmic they are. But if you use the embu, they how so they is a flat line, then a sharp. So the difference in the lung is very clear. On the left hand side, the lungs are well expanded. However, on the right hand side, expiration without PEEP, the lungs are at electrotrauma, and that cause lot of problem. Even 5 minutes of atrial electrotrauma increase the risk of BPD, and that is true, madam, because now we even don't want to remove CPAP for 5 minutes. We do not want to intubate also for 5 minutes. Western countries have stopped intubating for surfactant. Malignant hypertension. Malignant, I think so. I've written a wrong. Oh, this is not malignant hypertension. This is malignant PPHN. I'm sorry. Malignant PPHN is a term when even in a TTN baby who are delivered by LSCS, we start giving oxygen. Oxygen is very, it gets absorbed into lungs in a second, in a minute. Sometimes prolonged use of oxygen, the oxygen get absorbed and there is atrial electrotrauma. That leads to PPHN. Sometimes अभी तो बच्चा ठीक था, आधे घंटे तक तो ठीक चल रहा था and suddenly crash हो गया. इस तो ऑक्सीजन रिक्वायरमेंट बड़ा मेंटेन ही नहीं कर पा रहा. Madam, those babies who require more than 40% oxygen in delivery room should be given a positive pressure ventilation. It should be CPAP. The machine I told you is Neopuff. So absorption atelectasis and reactive oxygen radical injury cause malignant PPHN. I've told you this is now this sucrose solution is available in India. Just 10 rupees one bottle. Just 10 rupees. Not even if it is not available. Even if it is not available, you can just give 25% dextrose, 1 to 2 ml pre-transfer before IV access, or in any babies who was born to diabetic mother. 25% dextrose or 24% sucrose. Even up sucrose to 40% is allowed. One intervention, I'll say, just 10 rupees can say it can do wonders. Hypothermia, if we increase our OT temperature from 20 degree to 23 degree Celsius, it makes a lot of difference. The intubation decreased by 1/3. Ventilator use decreased by half. Hypoglycemia decreased from 6% to 4%. Umbilical artery, pH increases. So this is how we do. It's just a plastic, food grade plastic. If not possible, whatever plastic sheet you use in dressing of your patient, in the mother, the same can be used. Just the same can be used. A sterile apron can be used. Just cut it to baby size and cover it. As soon as the baby is delivered, less than 32 weeks, just cover the baby. Just cover. And the morbidity really comes down at a temperature between 36 to 37. And one more thing, sometimes overwarming also is harmful, especially those babies who are preterm or hypoxic. Food progression, shift trial was there. It was less than 32 weeks, and they found out early aggressive feeding, 30 ml per kg per day. In standard language, if I'll say 1.7 ml per kg twice daily. So 1.5 kg baby should be increased by 2 ml every 12 hours. You have to ask your neonatologist or pediatrician, are we increasing the feed? What are the contraindications for stopping the feed in this child? If you do not ask, we will be always scared. Have you consulted somebody else? If you feed the child, the infection will come down, the baby will receive probiotics, the baby will receive the balanced nutrition, the gut will not be fasting, the villi will not be, hypoplastic. It will increase the outcome way too much. NEC rates have not increased. Faster increment, NEC rates were lesser. Median time to reach full feed has come down from 10 days to 7 days. The IV line is going to remain lesser, at least 3 to 4 days. Madam, we increase by 40 ml per kg per day, and we, even in 24 weeks, we reach full feed by day 4, most of them. Unless it was a severe preeclampsia, those babies we do not feed for first two days. That is the absolute contraindication. Absolute contraindication is high inotrope, mother having preeclampsia, or the baby is severely sick. Ventilator, baby on ventilator or CPAP or NIPPV is not a contraindication for feeding, at least for trophic feeding. No. That is the outcome. Even for formula, sometimes we say there is no milk available. Formula is better than fasting. One thing is, formula is better than fasting. EBM is the best. This thing I want every gynecologist to know. Sometimes they are on the bedside and the pediatrician or neonatologist just come for a round, and every time gynecologist is there. We have developed not me, the neonatology team have developed a stop score, and the stop score is very easy to remember. You will just tell your on duty doctor that we have to check 5 things: sensorium, temperature, oxygenation, perfusion, and sugar. If 2 out of 5 things are abnormal, sensorium, the baby is dull. Temperature is, the baby is either hypothermic or warm. Oxygen, the babies require oxygen, or the oxygen support has increased than previous. Perfusion, the baby has not passed urine, or the baby's skin looks mottled. Or sugar, any sugar less than 50 or a sugar more than 150 should raise an alarm. Fasting sugar should raise an alarm for sepsis. 2 parameters abnormal it is likely sepsis. 1 parameter abnormal for more than 4 to 6 hours is likely sepsis. So ask your neonatologist or pediatrician what is the cranial ultrasonography. Day 3, day 27, day 7, or sometimes people change it to day 3 and day 10, and that is for babies less than 30 weeks. More than 30 weeks, we can just do 1 ultrasound at day 10. FiO2 monitoring, like sometimes we just keep on giving oxygen. Our target of baby saturation is 92, not more than 95. So sometimes pediatrician or neonatologists are scared. We want to keep the saturation to 98, 99. That hyperoxia causes a lot of damage, a lot of lung damage, brain damage, increases in NEC. So not increase in NEC, sorry, death. So saturation target should be 92 to 95%. One thing I'll request those babies who have been growth failure. It's not for gynecologists, but you can ask your pediatrician, sir, एक बार urine sodium करके देख लो, and urine sodium should be more than 30. If the urine sodium, अगर कई बच्चे होते हैं grow ही नहीं कर रहे हैं, just one test is, and most of pediatrician don't know, एक urine sodium करके देख लो, urine sodium अगर less than 30 है तो मतलब you instead of feed you need to increase sodium. Enteral feed अगर कोई नहीं कर रहा है, pediatrician not feeding the child, नहीं feed नहीं कर सकते, you ask him what is the specific contraindication. अगर एब्डोमिनल माइल्ड एब्डोमिनल डिस्टेंशन है वो सीपैप की वजह से तो नहीं है, द चाइल्ड इज ऑन सीपैप, उसकी वजह से तो नहीं है, आर द एस्पिरेटेड, द बेबी पासिंग स्टूल और नो, एंड वन इज एंटीबायोटिक प्रोटोकॉल, आर यू गिविंग योर एंटीबायोटिक जस्टिफाइड, अनजस्टिफाइड एंटीबायोटिक डू much more harm than benefit. This is for infection control. We have alcohol hand rub and alcohol swabs. Like we have to clean the hub for at least 15 to 30 seconds. Those babies जो हम hub clean करते हैं, no preparation, lot of the bright spots are the bacteria, and 15-second preparation is no bacteria at all. Low cost strategies for gynecologists, the WHO paper recently, folic acid supplementation, tetanus toxoid, malaria treatment not for India, but detection of asymptomatic bacteriuria, decrease neonatal mortality by at least 20 to 50%. Asymptomatic bacteria also need to be treated. Antibiotic for preterm premature rupture of membrane, decrease mortality by at least 1/3. Steroid decrease mortality by 40%. If a breech preterm is there, it has to be delivered LSCS, decrease neonatal mortality by 70%. Clean delivery practices, 70% prevention mortality. Similarly, if there are the neonatal outcomes, trained pediatrician will decrease mortality by 6 to 42%. Breastfeeding, single most important. Sometimes दूध नहीं आ रहा formula दे दो. No, madam, no. Formula is for support, not for replacement of breast milk. Breast milk. There's no way out of it. There's no way out of it. KMC, big way helping, especially the preterm child. Prevent mortality, decrease hypothermia, decrease infections, decrease length of stay, exclusive human milk, decrease NEC, aggressive feeding, decrease NEC, antibiotic use, necessary, yes, unnecessary, wasteful. So this is one last slide I'll say, promotion and colonization of normal bacteria by KMC, breast milk, probiotic, and decrease antibiotic, prevention and colonization of with pathological bacteria, decolonization strategies, hand hygiene, skin is antiseptic, hospital acquired infection, hand washing, and training of the staff and maintenance of skin integrity. You can use oil, massage, or do not put very strong adhesives over the body of the child. I think this is a just summary. Steroid, MGSO4, delayed cord clamping, oxygen, temperature. That is from me. Thank you so much. I am so humbled. I've been given a chance. I thank you, Dr. Sharda, and all those involved. Please. So I with so many beautiful ladies I'm talking to. Thank you so much, ma'am. Thank you.
I think, sir, it had been wonderful, wonderful.
Marvelous,
सर
marvelous.
इसको stop कर देंगे presentation को, so we
Yes,
can
ma'am.
see many
Yes.
people.
Yes, ma'am. Yes, just a minute. I think.
Dr. Ashmita, by words by you. Ashmita, are you here?
I think still left.
Sangeeta, you start. Dr. Sangeeta.
I mean, it's a beautiful, it's a wonderful talk by Dr. Hemant. Every word was the golden word. This much only I can say. Every word was the golden word. Right from indication of termination of delivery. Today only I had a patient where I was having a dilemma in my mind that she's a severe hypertension and she was just 29 plus 4 days pregnancy and there was absent diastolic flow since last 3 days. Today also it was absent and I was waiting that what decision I should take. She is already on high dose of antihypertensive. So you made it very clear that absent diastolic flow you can go up to 34 weeks. As far as a fetus is concerned.
Absent 32 week, ma'am. Absent 32 week, reverse 30 week. But less than 30 week, no.
Absent and diastolic 32, of course, 32 to 34 weeks as per the
Yes, ma'am. Yes, ma'am.
So I think that cleared my confusion. Next, what you have said and what I experienced, and I have been repeatedly listening that it is very difficult to unlearn rather than learn. So for pediatricians to unlearn what they have taught is difficult, but we gynecologists can learn right things by your teaching. So I think we need these type of presentations again and again. Though today I remember all the thing what you have said, but tomorrow I might forget. So I think you should share your PPT, and I think 50% of your slides of PPT should be there in a medical college labor room as well as an ICU, because every line is a golden line. What you have said, if we follow it, much of our tension, our hospital expenditure and referral from hospital to another care facility because of non-availability of ventilator will be decreased. I think it was, I mean, I don't have any words to say because मैं भूल जाऊंगी जो भी कहती जाऊंगी जितना retain किया है. But it was a wonderful, wonderful talk, Dr. Hemant, and please repeat it at least once in a month for first 4 weeks, then once in 5 months for next 4 weeks, then only we will remember it.
Dr. Kiran Chhabra. Dr. Kiran.
Good afternoon, everybody. Sir, your talk was excellent. You had given so many small tips for each and every gynecologist to remember. 2 things I want to know from you. Recently, while cord clamping, delayed cord clamping, 2-3 patients I have seen that I have come across with a new term which is polycythemia in a child. And for that, the baby was kept in NICU for 3-4 days. And finally, what they did was just giving 20 ml saline in the cord, and after 3 days, they released the baby. So how to go about it? This is my question from my side. Secondly, you said about prematurity mainly. So all these things have to be taken care of in the term baby as well. What do you say?
Madam, first of all, about polycythemia, ma'am. I don't know. Strangely, we have not come across that polycythemia requiring treatment. What we say, polycythemia, any child hematocrit, the PCV more than 67 is a polycythemia. But what my boss have been telling me, and I've been reading, only those babies who are symptomatic polycythemic, especially those PCV goes beyond 75 need treatment. Prophylactic treatment for any child having polycythemia is not indicated.
Okay.
Symptoms mean hypoglycemia or the child get dull. Only then we have to treat. Otherwise, those children do not have any business to going to NICU. The problem with us is we are way too many now, and the cases are really coming down. The pediatricians are ideal, so we're just taking the babies to NICU unnecessarily. And sometimes they don't know they are going on the 67 hai, kahin kuch ho na jaye. So we are doing more prophylactically. Now the treatment is not prophylactic. No, if there are symptoms, no child is going to die because of polycythemia. They're going to die if we do not treat symptomatic polycythemia for long. So I think that is unwarranted.
Okay.
Second thing is prevention of hypothermia, hypoglycemia, infection is same for preterm and term child. Yes, preterm is required more, but if can be done in term child, that is no harm. That should be done.
Okay. And what about the feeding formulas inside the NICU? Because the baby is not with the parents and or the doctor or the staff. So inside the NICU, is the formula milk sufficient, or we are doing something else regarding that?
Madam, antenatal counseling should start for breast milk. Breast milk is not prepared in the breast. It is prepared here in the brain. The dopamine gets secreted, and then oxytocin, those reflex, and then the let down reflex come. If the mother is convinced, she's dedicated to this, she'll express. At least by second day there will be enough milk. We do not have a milk bank, but we are never short of milk. Okay. Never, even for twins. And preterm don't require how much milk they require. They require 1/3, 1/4 of the term. And mother starts, having lot of milk. So it will never be a problem. Formula should be the last resort, but better than IV fluids. No child should be kept fasting because there was no milk. Otherwise, by second, third day, every mother will have milk. And if the parents agree, we can share milk also. If the HIV, if there's no HIV or hepatitis, we can just tell them that this mother has enough milk and the HIV and hepatitis B reports are negative. Do you want to share some milk for some time? By third day, you will have enough milk. And if not possible, you can ask the milk bank. There are a lot of milk bank in government sector and private sector also. If they can help you out, you can just start with this.
Okay. Thank you so much, sir.
Dr. Ashmita, are you there? Ashmita?
Very nice.
Yes, ma'am. Yes.
Please, madam.
Yeah. Sorry, I got disconnected. Some technical issue for minutes. I think it was a wonderful presentation, and it's very important that we use all these non-invasive techniques, and all obstetricians are aware about it, so that we can at least discuss it with our pediatricians and neonatologists. One, in terms of a better outcome, and second, in terms of reducing the cost of an intensive care in the neonates. And all are very simple, doable things. I mean, there is no rocket science in what sir has told and he has explained to us. So I think awareness at our level, as well as our sort of proactive approach in asking our neonatologists to do it, can go a long way. Thank you. It was a wonderful presentation, sir. Really eye-opener in true sense.
Alka, you want to say something? I have to wind it up at definitely
Okay.
at 5 to 2.
I'll say thank you, ma'am. Thank you, sir. It was really very informative. Thank you very much.
Dr. Archana, you want to say something? Archana?
Ma'am, I only want to appreciate that what I can say at that this time that even the first slide was too good, and I mean it was a wonderful all four P's, that prematurity prevention from gynecologist standpoint and the preparation and protection and progression. That slide is in my mind, and so really awareness is much needed, and very simple doable thing, as Dr. Asmita said also. Sir, wonderful. Dr. Hemant, I can say it was like a AB, Amitabh Bachchan type of presentation, where each and every word is really to the mind. Especially the thing you said, truth is, if you are not thinking about disaster is about to come.
I will wind up here by saying, your talk has to come time and again. It was Fedora box. It has changed our thinking so far, and I think it's high time that you should take initiative to train your colleagues as well. We
Yes.
gynecologists will get trained by you, but you have to train
Yes.
your colleagues
Yes.
as well.
True,
I think,
true.
I'm going to wind up here because, our next session is already there and, people are calling me from there. So
Okay,
thank you
ma'am.
very much, Dr.
Thank
Hemant.
you.